All right, we will go ahead and get started. So thank you everyone for joining the October Behavioral Health Advisory Group meeting. We have a wonderful panel today, so very excited to get started today. So just continue to introduce yourself in the chat, and our agenda for today is as follows. We're going to do a quick round of introductions, and then we are going to jump right into our panel discussion. We have 3 panelists joining us today. Very excited to welcome them into our meeting today and hear from them about reentry programs in Prince George's County and addressing the mental health needs of individuals transitioning from the justice system. We'll then open it up for some open Q&A time for you all to ask some questions to our panelists. As always, we will wrap up with our community announcements, and then we will adjourn by the 4:15 hour if that works for everyone. All right, and for those who are new to the PGHAC, if you would like to unmute and go ahead and introduce yourself. Otherwise, if you'd like to put your information in the chat, do feel free to do so. But do we have any new members joining us today who would like to introduce themselves?
Hi, everyone. Can you hear me?
Yes, we can.
Hi, not sure if I'm a member, hope to be, but my name is Tara Davis Ramah. I'm the program director at Nimble Mental Health. The department I run is substance use disorder, trauma, and mental health. So I'm responsible for running the programs. We do daily groups, substance use, mental health co-occurring groups, also one-on-one. And we do a cadre of other things. So this is my 4th week here with the organization and just looking to connect with other community organizations. Thank you.
Wonderful. Welcome, Tara, and thank you so much for joining us. Any other new folks who wish to introduce themselves? All right, well, we were going to go ahead and jump into our panel discussion today. So we are joined by 3 wonderful panelists. Thank you each for giving up your time today to join us and talk about your program. So we are joined first by Dr. Gregory Bairstop. He is the Chief of Program Services in the Prince George's County Department of Corrections. We also are joined by Dr. Cheryl Wiggum, the Program Manager of Prince George's County's Offender Reentry and Reentry Support Programs, the Bridge Center at Adams House, and the Child Support Liaison in the Langley Park Multi-Service Center, as well as Mr. Michael Williams, Director of the Prince George's County, Maryland Returning Citizens Affairs Division. So welcome, you 3. Thank you again so much for joining us. So if we would like to first jump into some more introductions, Dr. Bairstop, we'll start with you and then go to Dr. Wiggum and Mr. Williams. If you would each like to introduce yourselves a little bit more and give us some context about your program and what you'll be speaking on today.
Okay, good afternoon, everyone. I hope everyone can hear me. Thank you, Taylor. I appreciate your introduction. Again, I am Dr. Gregory Bairstop, the Chief of Program Services here in the Department of Corrections. And one of the things I'll be talking about today is the transition of incarcerated individuals from the Department of Correction into the community, and some of the services that we are providing within the department that will make that a smoother transition. As you know, you've heard many times before, and how true it is that reentry begins within the Department of Correction. Really, it begins actually when they're booked in to the jail. So there's so much more that we're doing, and I'm excited to get into that after the rest of the panel has done their more in-depth introductions. So thank you very much.
I'll go next. I'm Dr. Sherelle Wiggum, and I've been with the Prince George's County Health Department for 24 years this month. I don't know if I should brag about that or I don't know. Anyway, but I've been here for 24 years and I've had the opportunity to manage a very large portfolio of programs for the health department, behavioral health services, which includes intensive outpatient and dual diagnosis treatment, community case management, prevention, diversion, and reentry services. And currently, I am the program manager for the Offender Reentry Program, Reentry Support Program, and Bridge Center at Adams House. And I will answer questions at request, but really pretty much today I'll be presenting about the reentry services provided by my programs. With that, I'll turn it over to Mr. Michael Williams.
Thank you so much, Dr. Wiggum. It's great to see everyone this afternoon. And thank you so much, Taylor, for the invitation. Again, I'm Mike Williams. I am the director of the county's newly formed Returning Citizens Affairs Division. I don't know how much longer I can call it new. It's been about 1.5 years. Dr. Wiggum would probably say we aren't new anymore. I still like to claim some newness here. Our office was created as a result of the Reentry Advisory Board's work that took place starting in around 2018, 2019, where the county executive and the then chairman of the county council came together to really strategize and talk about the reentry landscape, or as we call it, the ecosystem of reentry in Prince George's County. That committee met for about 2 years and came up with a host of recommendations, actually about 47 recommendations to be exact, one of which was to create a centralized office that would be responsible for coordinating all of the activities. As you can imagine, we're a large county. There are a number of public and private actors in the reentry space that provide a host of services to returning citizens, from the treatment, mental health and substance use disorder treatment, all the way up to workforce training, employment, and so forth and so on. And so our office was created to be kind of like that catalyst or the coordinator of all of those services to bring it into a single ecosystem. So just to be clear, we aren't necessarily a program. Our office is intended to be the coordinator, so to speak. And one of the things that I hope that we can talk about is the importance of partnerships in this work. No single entity can do this work successfully by themselves. Each of us depend on one another in order to be successful in this endeavor. And I'll give you a great example. I just had this conversation today. We have a new initiative that's coming out of the county executive's office and Employ Prince George's, where the county has agreed to hire a number of returned citizens in county positions. These are great positions, and we have our partner at Employ Prince George's, who is great at helping people find jobs and apply for jobs and secure employment. But one of the things that I've had to convince them and talk to them about is that not everyone is ready to work as soon as they come home from incarceration. Sometimes there's steps that need to be taken before the person gets on the job so that they can maintain the job. And so that's why the partnership with the health department and the Department of Corrections and the Department of Social Services, these partnerships are so important so that we all can come together to provide our returning citizens with the best opportunity to be successful once they come home.
Wonderful. Thank you three for that introduction. And you know it's going to be a good panel when you're already learning information and the questions haven't been asked. So you guys are all three rock stars, and thank you so much again for joining us. I want to invite the folks on the call, if you would like to put your questions in the chat, and at the end we will circle back and have some open Q&A time. But for our panelists, we have some questions for you. Feel free to answer in any order that feels most comfortable to you all. So our first question for you: in a continuum of care, when and how do returning citizens and/or families with a family member re-entering the community enter your program or office?
Let me unmute. I guess I'll start with the Bridge Center at Adams House and the reentry programs that we offer. We get many of our referrals from the Department of Corrections, Reentry Court, and other problem-solving courts, as well as parole and probation and state institutions. However, we do accept referrals from directly from families and community providers. All you have to do is call the Bridge Center at Adams House. That number I can put in the chat, or I can ask Nina to put it in the chat for me, is 301-817-1900. And that's the Bridge Center at Adams House. By calling there, you are connected with the Offender Reentry Program or one of our leads from the Bridge Center program. And basically what they do is determine the eligibility of the person seeking services. And the primary criteria is that you are 18 or older, that you are a resident of Prince George's County, that you have a history of substance use or mental illness or some type of history around that. We don't care how minimal it is. And from there we determine which program we associate the individual with. And so we provide screening and assessment and clinical case management. And something that Mike mentioned was that we depend on the collaboration of partners. And so the Bridge Center and the reentry programs operate under a collective impact model. And basically what that is, it says something that Michael said was that we can't do it all ourselves. We don't have the capacity to do it all ourselves. So we depend on having those partnerships with community providers to provide the services that our returning citizens need. And we do monitor and evaluate the effectiveness of the services that are being provided to our clients, because we want to make sure that they are getting the best services to meet their needs. I don't know if Mike wants to add anything to that.
Now, as I mentioned, our office is not a program. So anyone that comes to us, and we do get people that call, we have family members that call all the time. I guess we're on the county's website. My colleague, BJ Page, and I, we travel the county and the state, really talking about Prince George's County and what we're trying to do in the reentry space. So everyone that calls me, I refer to Dr. Wiggum.
Yeah, I was going to say, we get referrals from RCAT as well.
So one of the things that we've been trying to establish is that the Bridge Center at Adams House is the county's hub for reentry. So we want all the men and women who are coming home from incarceration from state, local, and federal facilities to go by the Bridge Center to get connected with the services that are offered there. So it's kind of a one-stop shop. And I'll let Dr. Wiggum describe her program when it's appropriate, but everything is there. Everything is contained within the Bridge Center that a person would need in order to be successful. And if they don't have it within the Bridge Center, they certainly have the wherewithal to make the referrals out so that people can get the services that they need.
And I'll just mention that the services that are, well, one, I'll mention that we're here Monday through Friday. We open our doors to the public from 9 a.m. to 4:30 p.m. Generally, I have staff that's on site as early as 7:30, but usually if they're seeing someone, it's because they have a scheduled appointment that early in the morning because maybe they have to get to work or something like that. But we have employee Prince George's on site, the Department of Social Services, Maryland Health Connections, Catholic Charities, National Association of Black Veterans, and we're also just Community Legal Services is coming on board to provide expungement 1 day a week. So our service providers are here on certain days and times, but we are open for services, welcome in referrals, and we connect. Like I said, our case managers will connect clients with the appropriate program. We also have peer support specialists on site in our reentry support program. And so they supplement as a best practice to being able to provide that lived experience and assistance to our clients.
And Margaret, I see your hands up if you'd like to go ahead.
Okay, thank you, Taylor. Yeah, I was just going to say this is wonderful. You know, it seems like you guys are doing a great job. My one question was, and I think this is like, how do we help support you in that? What system do you have like a data platform that could be, you know, an ability to receive referrals, make referrals, and seeing if, you know, sort of like they do from the medical side, right? You know, you send a referral for a chest x-ray, you get the chest x-ray done, you know, it's completed, and then sort of these warm handoffs. Do you have anything like that, you know, so that it's coordinated and that you can keep track of, you know, what's happening? Because we're TLC is in the process of building a dire care center. So we're looking at referrals coming in and going out, and just want to see, you know, how there could be some synergy even with data collection and coordination of care for these individuals.
Which I think is a very good question. Right now, with the database system that we use is Efforts to Outcomes, which is ETO is the acronym for that, and we're looking at joining the county's database system, which is Epic. And I don't know if there's going to be a connection with the Dyer Clinic opening, if they will be in Epic or not. I was wondering if my program chief who's on might know that, what the plan is.
I'm not sure what the database plan is for Dyer Clinic right now, but I imagine we'll develop synergies between what we're using and what Dyer Clinic ends up selecting.
Right now, I'm going to look for, I believe it is Bridge Center at Adams House at co.pg.md.us. Don't quote me on that. I'm going to try to get the correct, but you can send referrals to that email address. And basically all you have to do is say, I have a client, I believe they are appropriate for your services, give us their contact information, and we will reach out to them and let you know that we received your email and are reaching out to that client. But we would enroll them in our database and provide services and document in our database. And so I like I said, in the future, we're looking at making that connection with Epic, which is the health department website, not website, database, so that we can have that. And instead of being like on being the lone ranger of the health department, being connected with our own services. So I'm not sure how all of that is going to play out in the future.
Hey, Margaret, is there a shared database system that you guys are using now?
Well, what we're doing right now, and you know, thank you for that answer, Dr. Wiggum. We're just right now developing a centralized data warehouse and a data dashboard for the emergency crisis system. So I just wanted to make sure that we could align if that needed to be, or have some discussion. But you know, we work very closely with the health department, so I just wanted to make sure that, you know, we were aware, so that was we're planning to build this dashboard for the emergency crisis services. These are those little spokes on the wheel we talked about. So I just wanted to make sure that, I just wasn't sure what system you were using, because then we could start looking at how that could be integrated. It's more about data integration and making sure that we can do that, not changing everybody's platform, but how do we identify residents that are utilizing these services across the continuum of care. So that's why that was just a question, but so thank you for that. And I'm glad, at least, if we're moving to Epic with the county, then everything we should all get it connected.
We would hope so.
Well, well, that's going to be, I think Nina and I are really honed in on that. So, and we have a team between the health department and Dr. Somerville's team. We're keeping a really good pulse on that with all the programs and making sure that we can share information as needed. And then having making sure that none of our residents drop, for whatever, we want to provide that warm handoff.
And I'll add that the person who we have working on the data warehouse, Margaret, with you, is also our database expert on the Bridge Center piece of it. So he's already gotten the nudge that we're going to want all of these systems to talk to each other. And I think that really pulls in our next step, which would be our systems talking with Dr. Bairstop's systems. And to his point, starting at the very front end of this spectrum so that we're getting ahead of the reentry stage and really planning for that effectively. So let me turn over to you, Dr. Bairstop.
So thank you, Ms. Ward. Margaret, just to answer some more, Dr. Wiggum mentioned that the health department uses the ETO, efforts to outcome. So it will be good for you to know that here in the Department of Corrections, we use that too. So once the interface happens with ETO and the county and the larger networks interface, then that would give even more an idea of graphics, who the continuum of care, where the client has been originated from, and their walk through the continuum care. So we do utilize that here in the Department of Corrections in our rebirth program. Our rebirth program has just been fully accredited by CARF. It's our substance use treatment program. So and that is our main system for rebirth. The other thing I may be a little bit premature to say, but I will throw it out there to everyone on the call, is we also are looking and working within our Department of Corrections to, we are utilizing the Pocket app. Now, this is an app that people leaving it's spelled POKKET, that are leaving the department can connect with all kinds of services in the community in case management, because they can, well, hopefully by January or into March of 2024, we're trying to get the app on our all our incarcerated individuals here in the Department of Correction have a tablet. So they all have tablets now. So, and we're trying to get the Pocket app downloaded on the tablet. So even if they're incarcerated, they still can have connections in the community with a provider. So wouldn't it be nice to have therapy on your tablet with someone, a provider in the community, and you're still incarcerated in jail? So these are the vision that one of the visions that we have here in the Department of Corrections. We again, everyone has the tablet. Ms. Kokanam, who's on, Chief Kokanam is our chief, she's on the call here. She's our chief of the Community Corrections Division here in the Department of Correction. And she is really the lead person on our working with the Pocket vendor. So she has case managers that are utilizing it when people are on home detention, home monitor, and I'll let her speak on that. Um, uh, Ms. Coconut,
Good
you here?
afternoon, everyone.
There you are. Can you talk a little bit about that?
Yes, I can. So just to build up on what Dr. Bierstuff had shared, the Pocket app is a web-based tool that we use to link our returning citizens or individuals returning back to the community to resources in the in the community. And what we're trying to do with that in the jail right now is the company in itself is civilly overseeing the Pocket app has a secured IP address where we're able to interface so that we're not breaking any security rules or we're not violating any kind of security where clients are talking to each other or anything that's not supposed to happen on the inside or the outside. So it's very secured. And because they've used it in Georgia for a while and it's evidence-based, we know that it works over there. So we're trying to bring that to our jail as well, whereby we're able to provide services in the jail and link them to resources in the community. We're already using it in community corrections where our home monitoring programs are already using it. Our reentry case managers are already using it to link our clients to resources in the community. But the thing about it, the companies or the service providers we're collaborating with has to be trained in Pocket. Their information have to be built into Pocket as well. So it's just a matter of basic training. Once the training is done, it's very straightforward. The other thing with Pocket is that the clients are very engaged in it as well. So when we're referring clients to a service provider, the client has to accept that they want to be a part of that program and that they want the information shared with that service provider. So nothing is being done without the client's permission. And that actually assists with establishing trust with our clients because they're very much involved in every step of the process.
Thank you for that, Chief Cocono. I was wondering, are those tablets given to them when they leave the jail?
No, because it's
okay.
a web-based tool, they can continue on with the information. So what we do is shut it off because we have the pre-release side of it and we have the post-release side of it.
Okay.
What they're able to do is carry the information in Pocket with them, and they're able to access it on any device in the community as long as it has Wi-Fi. So they're able to continue on in the community. We just shut the pre-release side off and turn on the post-release side.
Yeah, because my thought was this, I'm just thinking, just brainstorming a little bit, but, with the emergency crisis services that are being implemented with the MRT, the mobile response teams, the dire care center, that those might be able to be added as they're exiting the correction system and entering the reentry, just again, to give them that extra support they need. So,
Yes.
So thank you for sharing that, because I would like to try to figure out the opportunities we might have to make sure they have those, emergency crisis resources to help them, because it can be very daunting to go, be discharged and then. But I know Dr. Wiggum and Mr. Williams are going to do a great job, but maybe just a little bit of extra support for them.
I would definitely say kudos to Mr. Williams because his office is actually helping fund Pocket. So, yes.
And I just wanted to mention that one thing that we are able to provide for our clients is a little different around those that are referred by parole and probation because we have to get permission through their probation officers. But we're able to provide Chromebooks through the Prince George's County Library System. Right now, the Chromebooks have Wi-Fi on them through the end of this year, through December 31st. But the funding is going to go away for that. However, we still have the Chromebooks, which we can make available to our clients, they just have to go somewhere where they can access Wi-Fi, which they can go to the library to use it, or basically any fast food restaurant or anywhere almost nowadays to access Wi-Fi, and they still can use the Chromebook as they need.
Dr. Wiggum, I'd like to talk to you a little bit more about the Wi-Fi access. Is it, maybe, is it through like Comcast?
I'm not sure. The library set that up.
Okay.
And I could probably find out who you could talk to in the library, who their tech people are, and who you could talk to about that.
Okay, that would be great.
So Margaret, the beauty of the again, the Pocket app too is, as Chief Kokenam had mentioned, is that even when they're release or post-release, um, a lot of our incarcerated individuals and just about everyone are connected through cell phones with their family and their friends. Cell phones are their life. So
Yeah.
to be able to now post-release install Pocket on their cell phone is a much better incentive, but also you're much better to able to connect and maintain the continuity of care because it's right on their phone, and
Right.
we're utilizing their lifeline, which is their phone. So that's one of the beauties of the Pocket app. That's why I wanted to bring it up.
Yeah, no, I appreciate that, Dr. Bairstow, because I think we're just trying to figure out how do we proactively give everyone that has that potential to have a crisis, especially when they're transitioning from one thing to another, that, we can, before they reach a point where they are in crisis, they can reach out if they can't get their therapist. And, that's what we were trying to figure out. How do we maximize everything we have? And like those spokes on that wheel, we want to be able to engage everyone we can and allow them to know how to engage before it gets to a point where they're having a mental health episode, police are called, and, it causes, a whole slew of things to happen. So if they know, hey, I'm not feeling so well, I can call MRT, talk to them, or 988 to try to bring myself down till I can make it to my therapist tomorrow. Want to make sure that we capitalize on those opportunities to now make that available to them when we know they're going to be transitioning. And then same thing with the Dyer Care Center. They're able to walk in and if they need help, walk there, get somebody to take them there rather than engaging police or going to the emergency room. So, again, it's just additional resources. I just wanted to make sure that we were able to connect with you guys and as additional resources to support them. And a Pocket Act seems like it would be a really great opportunity.
It is, and what you bring up too. I just got off another call because we have people that are either released from the jail and they have nowhere to go, and they end up staying or living 2 or 3 days in our lobby, and because they have, and this is most paramount. These are usually severely mentally ill individuals. So we just had a lady that was in the lobby. I spoke with her, but she was talking to 4 people. By the time I came back a few hours later, she was talking to 7. So how am I going to be able to connect with her? And then we're going to establish a meeting coming up with hopefully a lot of the people on this call for the very reason you're bringing up, Margaret, because often with the Department of Corrections, when we go to talk to the people who are severely mentally ill, right, they see us as punitive. You're the jail people. They don't want to talk to us. They don't want to engage because we have that association. But the people in the community, like the health department, and now I think it's Dr. Wiggum can tell me who it is. It's escaped me, but the crisis mobile unit is now with
I mind.
I
I
might.
might, thank you.
Right. Yeah,
Okay.
that's exactly who I'm talking about. That's who we partner with.
Mhm.
Yes, so those, so, we can call them and they come out, but, or, sometimes there has to be a petition for an individual. But uh, and we do have a van service that takes people to the metro station, but I don't want them to go into the metro station and they're severely mentally
Yeah.
ill to commit more offenses when they're not getting the help that they need. So uh, we're going to need to all come together and uh, make connections on this how we need to streamline and talk about continuity of care when people are living in our lobby. This happens quite often, really, and again, it's because of severe mental illness. But we can work together because often it happens, almost always, on a Friday at 5.
Yeah. Well, Dr. Bairstock, I
Always.
yeah, and I think we can learn from, I think models of medical care is you almost start planning the discharge upon entry, right? So, I think in knowing in advance that there is homelessness as an issue, then, and this is again, those spokes around this wheel that we can come together as a coordination care team around behavioral or substance use and and a lot of times I think a whole nother arena I'd like to talk about is, the whole chronic disease side, because then, we have that as well. But I think, with this coming together, and this is exactly what we want to do with all the people on this call, they're the spokes. There's, and getting those resources and those people aligned to be ready when, Mary Smith is getting ready to be released, that we systematically line them up to address the most urgent need upon, release.
So for everyone on the call, just so you know, what we're also doing in the vision of the Department of Correction, and we're doing it to some extent, but as we try to get more people engaged and for our community working inside the Department of Correction, the vision is to assess every person booked into the jail with the LSCMI, which the health department introduced to us. The LSCMI is a wonderful evidence-based tool for case management. It stands for Level of Service Case Management Inventory. So what I like done is everybody coming into the jail that they will get an LSCMI assessment, because oftentimes our incarcerated individuals, they don't even know what they need. So that's why it's important that we screen them, and then the LSCMI, it will indicate and identify high risk factors that will cause that individual to come back to jail and to all of those sequential intercept points. So this is why it's important, because once we can identify those risk factors, we can start them in programming inside the facility and continue it through our partners on this call in the community when they're transitioning back there. But I'm adamant that we have to assess everyone. At least it's not a mandated thing, but you'd be surprised all the people that want to be assessed, and we just don't have the staff or capacity. But we're going to make it happen. But everybody coming, if you make it to this far to get incarcerated, you need help. Everybody needs help if you got to us. So we need to be screening everybody at the onset when they're coming into the facility. And we do that with substance abuse. We do the DASH, which is the drug abuse screening test. Anyone scoring above a 3, they get referred to treatment in the jail to rebirth. But then if they're leaving and we know they're going back in the community, we refer them to our partners in the community. So I see Dr. Wiggle.
Yeah, and Dr. Biersup, I just wanted to say that, and I think we can talk about this offline, because I know that you have limited staff, I have limited staff, but I am willing to help with that process to see that the LSCMI is completed for everyone by volunteering or telling one of my staff that, once a week we'll go to the DOC and we will help with this process.
That will be
Because I
awesome.
strongly believe in it, because once they're post-release, we need that information too. And if we can have that plan or some idea what the plan should be way in advance, that's helpful to us as well.
Yes,
that
Dr.
would be-
Wiggum.
Well, we're open to even more takers. So thank you, Dr. Wiggum.
And we do, and so I'll also put out there that the health department does train in the LSCMI. We train others, we train our partners how to complete it because we need that assistance in getting the LSCMI completed as well. And it is a wonderful tool for case management for individuals that have a history of involvement in the justice system.
And along with that, Dr. Wiggum, and thank you for the volunteering, but also everyone on the call should know that the Department of Correction has a lot of partnerships, and we welcome, and we're partnering and we're receiving interns from the University District of Columbia who want to do their internship, and they help with the LSCMI. We have a partnership with the Howard University Divinity School now. They're going to be coming in. We have a partnership with Bowie State. They're coming in. We have Towson University in the house. So we've got a lot, and we're welcoming all of these universities to work with us as their students are very excited to get the experience of working with our population. So that's another aspect that everyone on the call should be aware of.
And Dr. Bairstock, we are happy to provide training in the LSCMI to those students.
We're going to reach out to you for that.
Thank you, Dr. Wiggum.
Okay, I was going to say that we paid a lot to have trainers in the health department. They should be utilized.
Absolutely.
And how would it be best for folks on the call to utilize these services or to reach out for more information?
I think Dr. Wiggum put her information in the chat, and Dr. Coconut, I'm jumping the gun here. Ms. Coconut could put her information in. I certainly will put my information in. So if anyone wants to reach me, you're always welcome.
Thank you very much for that. And in an effort to keep this problem solving going, I'm curious if you could all speak to some more challenges that you faced in the implementation of your work, and if there's any call to actions you can put out to the members on this call and how we can support you as a behavioral health advisory group.
I think I know for the Bridge Center, and I'm sure for others, one of the biggest challenges that we face is housing resources for our program participants. Transitional housing has increased in the county. However, transitional housing is like only one aspect of the population because they are structured. They have programs. Most of that their funding requires that folks have a substance use disorder, not necessarily a mental health diagnosis. So when it comes to finding the right housing for someone who is specifically dealing with mental health issues, that's difficult. That's very difficult. And also we have struggles or challenges with finding housing for individuals that are returning citizens and don't meet our criteria, exactly meet the criteria for the work that we're funded to do. And so, but we at the Bridge Center, we don't like to turn anyone away that is in need of help. Sometimes, people are actually not living in Prince George's County, so we have to refer them to Montgomery County for services, or um, the District of Columbia for services, and we'll do that. But there are people who come that are Prince George's County residents and that are returning citizens, but they don't meet the criteria of a behavioral health issue. And so it's hard to find that affordable housing piece for them. And the other piece about transitional housing and places like Oxford House is that they cost money, and there's most returning citizens don't have an income waiting for them when they are released. So that's a problem. There's just around housing, there are just so many issues. So that's one of the huge needs for us as far as getting support. And I guess the other are helping with our clients to obtain identifications. I know that I believe the way it works, that when they are released from the Department of Corrections, they have like 60 days, they have an ID that they can go to MVA and get an ID. But a lot of times, by the time that a person who's been released figures out, hey, I can't do this on my own, and they come to the Bridge Center, it's like past that 60-day mark. And then we're trying to figure out how to get an ID paid for them and processed. And there are some resources in the community that are helpful, but not always. And so, and then if you need a birth certificate, we can help if you are a resident or of the state of Maryland. We can get that through Vital Records. But if you were born outside of Prince George's County or the state of Maryland, then we don't have the funding to help you. And so it's there with everything, there are catch-22s in a sense. If I can't get my ID, I can't get my birth certificate. If I can't get my birth certificate, if I can't get my birth certificate, I need my ID. And so it goes back and forth, and trying to meet a need. I think we all we also are looking at the fact that we have community partners that provide clothing, but the essential types of clothing that our participants often need aren't back to work clothing. It's the underwear and the socks and sweatpants and things that just stay warm. Hats and gloves, and we don't have partners that generally provide those things. So that I'm just throwing those out there. I have a laundry list. I could go on and on, but those are kind of the primary.
I see Michael. Go ahead.
I just wanted to say that Dr. Wiggum is in the trenches, and so she is very in tune to like the immediate needs of the population. And some of the other challenges that I think from a system perspective really is getting a handle on the population. And so like we've been talking with Dr. Bearstop and Elizabeth about the population coming out of our county detention center. But we probably had about 2,700 people released last year from the State Department of Public Safety and Correctional Services. And so the problems that we are describing, while they aren't just contained to the county. And so and we have another federal population that's coming in that we can't even figure out how many they are, but they're coming back to Prince George's County. And then I've been saying this every chance I get, there's a population of individuals who are incarcerated in the District of Columbia or by the District of Columbia who are coming back from federal facilities, who are coming to live in Prince George's County because this is where their families have moved to during their incarceration, right? And so really trying to get a handle on what our population looks like. And I'm not sure how this group can help, but I like to put all the problems out there since we're giving the laundry list. Let's put it all out. but I think it's going to become even more significant as we go along, right? The population of returning citizens and their needs, both, the practical needs such as ID and clothing, as well as the more complicated needs such as healthcare and behavioral healthcare and substance use disorder care. I think we just have to really be mindful that we're in a posture that we can't even really define just yet, because we're still trying to figure out what the population looks like when we talk about reentry. And one of the things that I don't know if there's anyone on the call from the state probation and parole agency, but they are such critical partners in all of this that I don't think that we've tapped in, even as a county, I don't think we've tapped in enough to the probation and parole agents who are in the county who have a bit more leverage, because our reentry efforts are all voluntary. So no one is required. There's no condition of release that the court will impose. Well, they could, but they don't. But they've imposed to participate in the Bridge Center. That's a totally voluntary program, except for the reentry court people.
Yeah.
Everybody else is voluntary, right? And then I know that the state parole agency, it's not a condition to participate in reentry services. Though I did mention that to him when I had a meeting with him a couple of weeks ago. Let's talk about it, at least begin the conversation. And so there are a lot of challenges, but I think we have the infrastructure in place to begin to address them. But it's just going to take some time and some real creativity.
And just one last thing to build on what Michael was saying. For those people coming out of incarceration with severe chronic medical conditions, here not behavioral health, but medical condition, and we know that they're probably looking at that end of life preparation kind of thing, or end of life care, and not knowing where to place them, because the long-term care facilities are not taking them from incarceration. They're not doing bed to bed. So we have to find a way to release them to the hospital if we can. Then from there, where do they go? But just trying to see if we can build a relationship, connecting DOC to some of those facilities where we're able to get someone, instead of having to send them to the hospital, if we're able to get the judge to say, hey, you can release this person to this facility so they can get the care they need, bypass I'm not sure if I should call it the red tape, but right now I'm working with someone right now. I'm trying to find housing for this person. The only reason he's still here, yes, he's doing some time, but if I have a place to put him in the community, I can reach out to the judge and let them know that I have an address for him, and they will release him. Shelters are not looking for some, because it's not guaranteed how long he's going to be in the shelter for, or leave for what his care plan will look like. So issues like that are something that we also deal with here at the department.
And I guess as part of from our side as well, the other challenge is getting really to be able to address the violence. And I say this all the time. We talk about the opioid crisis. The opioid is a national pandemic. But guess what? For decades, gun violence and violence, so many people being murdered, that's a pandemic too. And nobody wants to call it what it is. So we having people come back in the community. They still have their guns. They know how to get the guns. They have not been framed in their mindset of how to deal with conflict. And so they go back out and take revenge, or they get part of something that's involved in revenge, or they fall back into old patterns of dealing with conflict, and then they're back with us again. Because the whole violent culture, we have a culture of violence. This way to solve everything is to do violence with our words, violence with our actions, and ultimately violence with guns. That you can hardly get a driver's license, but you can get a gun. And I know this because I'm in the housing units. I talk to the incarcerated people. I spend time with them, and a lot of them are here because of gun charges. And they all tell me they're going to carry a gun because where I live, everybody has a gun. And if someone carjacks me, I might have a chance to keep my car. Well, you're not going to keep your car. You may lose your life. So we have an awful need for addressing the gun violence and the way to refrain people. One of the things we've done, and I've started, is MTREM, Men's Trauma Recovery Empowerment Model, because a lot of this goes back to trauma. Just about everybody, once they get here, is traumatized. I can't tell you how many incarcerated individuals have bullets in their head as I speak. They're carrying bullets in their body. They're traumatized from that experience. But who's doing, we don't have enough people doing trauma intervention for our men, for our males. They're still living the behaviors and thought process of being traumatized. And so they come back in the community and they don't know how to deal with violence. They're in that sort of mindset. So and then they come back or they get killed. So that's another big challenge for us. That's the elephant in the room.
I want to open the floor for any reactions to some of those challenges that folks just heard of, or if you would like to raise any questions for our panelists, feel free to unmute or comment in the chat.
I would just like to say you guys are doing a wonderful service. My brain will continue to just keep thinking about how do we continue to meet some of those challenges. I think, Dr. Wiggum, clothing that you need, I think, we can certainly try to figure out together. I know there's always churches that are wanting to get involved and give the client clothing you need, not the, so that one we might be able to assist. Dr. Bearstop, the violence, I just started thinking, is there within this LSCMI system, I don't know enough about, the trauma, but is there a way to assess and maybe look for an evidence-based program that could, anyone that needs to, can be, while they're incarcerated, like you said, they're sitting there, and we might as well be productive and give them something to do while they're there. So, I can see, or I don't know if anybody on this call knows if there's an evidence-based program to help address those types of things for trauma victims of violence. That is certainly something that I think we should try to look into.
Well, the MTREM has been what we just finished an MTREM group, and it's Men's Trauma Recovery Empowerment Model, and it has been pretty effective. I can say this. I know Elizabeth, so Chief Kokodam will smile, but I try to keep performance measures. That's another thing that helps us in the facility, is see how effective our programming is and how we need to modify or improve. But with the last group that I and the Deputy Director Merritt, we just finished facilitating a men's trauma group. I can tell you that it is effective, because the reason why we went into the particular housing unit, because they had so many incidents in there. But the people that we had, about 15 people in the MTREM trauma group. We don't try to make it that large because it's less effective. We try to, but the most 8 or 10. But I can tell you, none of those participants were involved in any incidents during MTREM, and because a lot of the skills we talked about, and I can't tell you how many of the incarcerated individuals in the MTREM group, the participants, said they were so grateful because they've never had any forum where men can talk about feelings. The only emotion that society approves and most of us approve, subtly or unconsciously, for men to express is anger or violence. If a man says to someone, you hurt me, or they said to another detainee, you hurt me, what, you're a punk, so they can't do that. But in this group, they talked about it. They talked about what hurt them. So by getting that out and dealing with those things, it was very effective. And so I would like to, and they've asked if we can have more MTRIM groups in the community. Dr. Wiggum could probably share on this. I don't know if I don't know what MTRIM groups are in the community. We started on it.
Actually, Dr. Bairstopp, and I don't know if Nino want to chime in, because we have, the new grant that will be starting hopefully at the beginning of the year, adult reentry. And one of the when I was assisting in the writing of this grant, we requested training money, and some of that is for MTRIM. And I have reached out to Community Connections and their trainers about being able to provide that. So it's just, once we get the grant started, we do anticipate getting some more folks trained in providing MTRIM, because it's a wonderful evidence-based intervention. I actually many years ago studied under the person who developed MTRIM, and
Dr. Harris.
Yes. And she wasn't a doctor then, believe it or not. So it's I think it's wonderful that you all have brought that back into the DOC. And we definitely need to make it available in the community.
But it really is effective with the violence. Is one of you need more than that, but Miss Chief Coconut. Yeah.
I wanted to share that Kevin Williams of Damascus House and Metalworks are also trained. They've trained their staff in facilitating MTRIM, and the WTRIM as well, both of them. So we have a couple of providers in the community offering it.
Oh, that's awesome. I'm gonna need to get that from you, because there's sometimes some of these guys want to be referred, and they need to be referred. They've left already, but they never did complete. So.
Any additional questions for our panelists or any reactions?
Hi, thank you so much for the amazing plethora of information. I truly appreciate it. Question in regard to the training for the MTRIM, is that open for other organizations, or is it specific organizations that you're only working with and providing that training to?
I will, Ms. Davis, I will say that our trainings when the Bridge Center or the health department provides training, generally it's open to anyone who is in partnership with any of our programs. And if you want to, shoot me an email and just say that when you offer this, I want this training, I will tack it on my wall so that I see it and I remember that, to let you know when it's going to be available. But it probably won't be until sometime in the spring.
Okay. Thank you very much. Thank you.
And also, Ms. Davis, just so you know, you don't have to have a license to facilitate MTRIM. It helps to have the training, but it's not an evidence-based where you need a license or anything to facilitate.
Awesome. Thank you.
Wonderful. Well, we have some contact information here in the chat, but I'll just allow one last call for any questions. We have time for one last question if anyone has anything they'd like to share. And to our panelists, is there anything else you guys would like to share before we wrap up today?
You're on mute, Michael.
Yeah, I'd just like to say, I know all this time we're still doing this. I'd like to say thank you for the invitation. It was great talking with everyone.
And
Thank you each.
I'll piggyback on Michael and say thank you also for the opportunity to share about the Health Department and Bridge Center and reentry programs.
And I third Michael and Dr. Wiggum because it's always wonderful. We don't get thank you for creating this forum, providing the forum, because oftentimes what people receive on through the news and through word of mouth is all the bad things that happens in the jail, and they never hear about all the things that you all have heard about, and then they're not on this call, and it's almost like people don't want to put that on the news, you know. It's only the negative things that so it creates a very negative context of the department, and and it's not balanced. It's not balanced. So we thank you for any opportunity to be able to give a more holistic picture of what we do in the Department of Corrections.
Well, we take that gratitude and we multiply it by 100 and give it back to you all. Thank you so much for your time today. It has been completely invaluable, and thank you for all the information you've shared and for your partnership. I don't know about everyone else, but I'm feeling so inspired, and this has been truly so informative and really gives us some next steps to work on. So if anyone else has anything else to add for our panelists. Yes, many round of applause.
Thank you.
All right. Well, to our panelists, thank you again so very much. Do stay in contact with us. You each have the invite if you'd like to maintain attendance here with the PGHAC. So feel free to join us for our monthly convenings. And to finish this out today, we're just going to jump into some community announcements. If anyone has anything going on in the community that they would like to share before we wrap up for the day.
Just one last thing, because I'm so new to NIMBLE mental health, and it sounds like we got it covered. But if anyone looking for substance use disorder groups, mental health co-occurring groups, trauma groups, working trauma within that, we do offer that here at NIMBLE Mental Health. We also work with individuals as young as 4 years of age, all the way up into the golden years. So please feel free. We have a PHP, IOP, and an OP program here that we run. So please feel free to send us folks. I would love to partner and work in collaboration. And I know it was said we cannot do this work alone, but I truly want to thank the three of you, as I am a resident of Prince George's County, for the work that you do to help make Prince George's County the great county that it is. Thank you, each and every one of you.
Thank you for that, Tara. And an announcement that we want to put out to folks, I just put this link in the chat. If folks are able to complete this survey for the MedStar Southern Maryland Hospital Center's Community Health Needs Assessment, I put that link in the chat. If some behavioral health folks on the call would be willing to complete that survey to get some information to the hospital as they begin the CHNA process. That would be very helpful. It is open until October 27th at midnight if you are able to. And any other community announcements before we wrap up?
Yeah, Taylor, I would just like to prompt everyone about a town hall event that TLC is supporting Fund 988 with, which is going to be in December. We're currently looking for any supporters who would like to support with facilitating and coordinating that town hall. And what we're doing is just really promoting 988 and its efforts, as well as the actual fee that we want to get to help to sustain and stabilize 988 as its own entity. So if anybody's interested in supporting that, I put my email in the chat, and I'll also look for some correspondence related to that, please.
Thank you, Carlos. Certainly let us know any additional information. We would be happy to share that. out to our networks. All right. And if folks want to continue to put some announcements in the chat, and feel free to send that to us to include in the newsletter and out to the networks. But otherwise, we look forward to seeing you all at our next monthly meeting on Wednesday, November 15th, from 3 to 4:15 p.m. And thank you all so very much for all of your participation today. It was such a wonderful discussion, and please do let us know if we can be of any support in the meantime.
Have a great one.
Thank you.
Thank you all.
Thank you.
Have a good rest of
Goodbye.
your October. Bye, everyone.
Stay well, everyone.
Thank you.
Bye, Dr. Bearstop. Thank you.
Bye-bye.